Good afternoon, everyone. Thank you for joining us today. It's our last session in our age-friendly geriatrics education Tele-ECHO series on chronic diseases in older adults. Thanks for sticking around for the last 6 sessions, and we hope you found all of our sessions informative and useful to your practice. We have another ECHO series in the works, and we'll be in touch with you in the coming weeks, so be on the lookout for a future email coming shortly. Okay, so our session today is starting with our welcome announcements and introductions, followed by our interactive didactic and case discussion. Today's topic will be focusing on chronic care management of your older adult patients. And then we'll go ahead and move on into our closing and reminders. Just to make sure our session runs smoothly, you have been muted upon entry, and if you wish to speak at any time, please feel free to unmute yourself and introduce yourself with your name and location prior to speaking. Always maintain confidentiality when speaking about your clients by refraining from including any identifying information. As you all know, we are CME accredited, and our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. Today's session is accredited for 1 CME credit, and if you have attended all sessions in this series, you will receive a total of 6 CME credits. Certificates will be sent out by our CME office in the coming 2 weeks, so be on the lookout for that. They will be coming to your email address that you registered with. Okay. This project is supported by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. Okay, we'll go ahead and move on into our introductions as we usually do. We love to see where everyone's joining us from, so go ahead and include your name, role, site, and location in the chat box. And we'll go ahead and have our hub team introduce themselves. My name is Nika Seville, and I'm the manager for our Geriatric Workforce Enhancement Program here at UCI Health, located in Orange County, California. And we'll go ahead and have Dr. Campbell introduce herself, who's going to be our didactic presenter today.
Hi, my name is Sarah Campbell, and I am a family nurse practitioner. I am a health sciences assistant clinical professor here at the School of Nursing at UCI.
Thank you, Dr. Campbell. And Dr. Gurvich?
Hi, I'm Tanya Gurvich. I'm a clinical pharmacist. I teach at USC School of Pharmacy, where I'm a professor, and my practice site is UCI Medical Center, where I help out with patient care.
Thank you. And Dr. Sagal?
Welcome, everyone. I'm Sonia Sagal. I'm a geriatrician and clinical professor in the Department of Internal Medicine and Geriatrics, and I just want to welcome you all here today.
Thank you. And we should have Dr. Gibbs and Carlos joining us later on during the session. Looks like we have Carolyn Johns from Oregon here, Laura Langley from Nebraska. We have someone from Anaheim joining us, and from Alaska. We have some of our Jerry fellows here today. Thank you all for joining us, and I hope you enjoy today's session. I'll go ahead and let Dr. Campbell share her screen so she can get started with our presentation today.
Thank you so much. Go ahead. Oops. Share my screen. Can you see the PowerPoint okay?
Yes.
Okay, perfect. Okay, so today, thank you for letting me share, and I'm really excited to talk to you all about chronic care management. Of course, this is a topic that could be an entire course, and it is. Today, I just wanted to share a little bit about just kind of wrapping up this lecture series, just share about our approach to chronic care for older adults. And in thinking about this, kind of wrap up and touch on some of the topics we've already spoken about, but also just do some best practice sharing and have some discussion about what you all do in your practices and your individual clinics and practices, and share a little bit about the insight that I can give to you about what I've done in my own practice in my approach to patients and chronic care disease management. So our learning objectives today, really, in trying to narrow this down, is how do you pick what to focus in on? But our learning objectives today will really be to define the roles of clinicians and patients in chronic care management, to describe chronic care from really that health promotion approach, examine the 4 M's a little closer as they relate to chronic care management, and identify some techniques to really help our patients promote self-care strategies. And then throughout the presentation, I'll give you some, review some of the evidence-based resources to support chronic care management, both for clinicians and for patients as well. So it's a lot to kind of tackle in this hour, but I hope that we can have some good, rich discussion. So we know that chronic conditions are common for our older adult population. 80% have at least one chronic condition, but 68% of our older adult population have 2 or more chronic conditions. And this is relatively up-to-date data from 2021 in the National Council on Aging. And so this is kind of a snapshot of what our older adults suffer from. Of course, hypertension being the most common, but a smattering of just about everything, but at least 68% or more of our older adults have 2 or more chronic conditions. So that multiple chronic condition, having multiple chronic conditions is very common. So that multi-complexity, that 5th M, is really at play here. Chronic diseases are preventable. We know that 70% of cardiovascular diseases, type 2 diabetes, and 40% of cancers can be prevented with the following 4 activities. The first one, of course, being exercise, the second being diet, the third and fourth being smoking cessation, and then reduction of alcohol intake. So, and then we know that chronic lower respiratory disease is one of the other following these as well. So chronic disease, really some quotes that I like to just throw out here. Before you heal someone, you really have to ask him if he's willing to give up the thing that made him sick. That's Hippocrates. The other quote that I like is, knowing is not enough, we must apply. Willing is not enough, we must do. But one of my favorites is this one, and it's anonymous, but we eat ourselves into this mess. Now it's time to eat our way out of this mess. So I really like that one. I have a poll question I'd like to ask, and this is because really there's a very wide variety of emotional responses to chronic disease. And we don't often, I think, take time to really give space to that emotional response to patients when they're diagnosed with a new disease. I think that we, every day, we live, eat, breathe chronic disease. It becomes our second nature. And so we see a high blood pressure reading several times. Oh, you have hypertension. We see the cholesterol numbers, the diabetes numbers. You have diabetes, and it becomes something that is very common for us. But do we give space for patients to react and to sit in that emotional response to the chronic disease diagnosis? So I wanted to go ahead and put up a poll. So if you don't mind, so the question is, do you ever ask your patient, how do you feel about this diagnosis? So the first being never, second rarely, sometimes, and then often. So do you ask the question, how do you feel about your diagnosis, whatever that diagnosis is? So give you guys just a minute on that one. So Nika, I'll let you run that. When you see that most everybody's answered the question, you can post those results. Okay. So it looks like sometimes and often, which is great. So so an even split between sometimes and often, which is really good. And so creating space for discussing with patients how they feel about their diagnosis is really important. And this is something that not everyone tends to do. We also don't give time to really explore how that feeling directs what they do about it. And so this is a part of what we'll talk about today when we talk about kind of motivational interviewing and how we direct their plan and treatment. So we'll go ahead and close that poll. Thank you for answering. Slides. There we go. And I want to really talk a little bit about role definition. With chronic care, this is something I do, and I'm not sure if any of you do this, and I will ask that of you in just a minute, but role definition is really important. In chronic care management, it's really important to set aside and frame the role of not only the patient, but the clinician. So in doing that, we need to do that because managing chronic disease, not only in primary care, but in acute care setting, is really difficult because it's somewhat like rowing a boat in rough waters. Sometimes we feel like we're rowing the boat upstream, but we need to define our roles, and taking time to do this really kind of sets the tone for the patient and for yourself. Clinician burnout has become a lot more prominent, especially with the onset of the pandemic. And so defining the role of what we do as clinicians and what the patient does and their responsibility can really help to mitigate some of that burnout, but also engage the patient and provide them with a sense of ownership. So the patient and caregiver can begin to engage. And so I like to use an analogy. And what I do with my patients is I explain to them that their disease is like a river. So the river is their chronic disease, and they may encounter rough waters ahead. But really, when they get in the boat, I, as their provider, am going to give them and provide them with their treatment plan. Their treatment plan may be a set of oars. The set of oars is something we get to choose together. And sometimes different things dictate what those oars are going to look like. And what matters most to them is going to probably determine which set of oars we use. However, I'm not going to be the one rowing the boat. The patient is in the boat themselves, and they're going to be rowing the boat. I don't get in the boat and row the boat for them. They really have to row the boat themselves, but I'll stand on the side and I'll coach them with a megaphone. So I'm going to say, hey, there's a fork in the road, and you get to decide which fork to take based on what matters most to you, but here's how it's going to look, and I'm going to coach you through this, but I can't get in the boat and row it for you. You really have to be the one that takes ownership of how you navigate these waters. And so that really takes the ownership off of me and off of the burden off of the care, the provider, and onto the patient. And sometimes it really helps the patients to understand that they're in control. And sometimes I think that patients expect us to get in the boat and row it for them. I think that there's sometimes this codependent relationship that begins to develop sometimes. And it's really helps, I think, patients to really understand what their role is. That they really are in the driver's seat. And sometimes that gives them that sense of control, that I'm not the one directing their care. They're the one directing their care. They're the one that gets to row the boat, but I'm there to coach them. I'm there to cheer them really from the sidelines and say, hey, you're doing a great job, but hey, I see some rough waters ahead. Here's how we're going to get through this. Which way do you want to go? How do you want to do this? There's a fork in the road, in the river. So, and so that's one way to really help at the beginning of the diagnosis. And it really helps to have that discussion beforehand of how are you feeling? We're about to get in this boat and I'm going to coach you through this, but here's your set of oars. Health promotion strategies, and this kind of goes along with that river theme. We want to approach this from a health promotion sense of being. In 2011, the Institute of Medicine, now of course we call it the National Academy of Medicine, but they came up with a collaboration, a committee on living well with chronic diseases. And this really was a call for public health initiative to the idea of health promotion within chronic disease. And that is really to look at how can we promote wellness within chronic disease. And for the 65 plus population, we often don't think of health promotion strategies or primary prevention. We think of, more the downstream effects. And so we're going to talk a little bit about levels of prevention. And we tend to focus here, right? We think of 65 plus, we usually get them in that secondary and tertiary level, but we really want to think about all the levels of prevention. So in the primordial level, we look at before they're jumping in the stream. This is when they're on the shore. This is minimizing hazards to health. And we can still do this with our seniors. We can still look at policies really to promote and protect health disparities. And we can be a part of that. But primary prevention, really preventing disease through minimizing risks. We can continue to promote healthy behaviors and educate our patients before they have disease. And we can do this with our seniors. But really looking at secondary promotion, screening at-risk individuals and promoting early detection. So we've highlighted these areas because this is typically where we think of, our 65 plus population. And we'll talk a little bit more about how we can do that more specifically. But really, they've already gotten into the river. We need to give them their life vest. We need to mitigate those risks and really focus on early detection. And here's how we can do some of those things. With the screening, in USPSTF and utilizing some of our evidence-based recommendations, we really need to focus on those age-specific recommendations. We can use expert guidelines, really things like the American Geriatric Society, but really consider prognosis. And we talked a little bit, I think it was our first lecture that we did, and we talked about prognosis and really considering, is this right for my patient, and making our recommendations for preventative care very individualized, not using a blanket statement, but looking at their age, their prognosis, and what's right for this patient based on what matters most to them, but also what's right for them as an individual. We can also look at resources such as Choosing Wisely for Older Adults. And I have a link here. And these are 10 things that we really should be doing and not be doing for our older adult populations. So if you're familiar with Choosing Wisely, it's a great resource for age-specific guidelines, but these are more specifically for 10 things that we should and should not be doing for older adults. So you can check that out there. But we want to educate and continue to provide anticipatory guidance. I had a patient once that when we were initially talking about her new diagnosis of type 2 diabetes, we began to talk about her risk factors. We began to talk about her family history and about kind of what was to come. So preventing further deterioration, kind of in target and in organ disease. And she had never made the connection that she had multiple family members with type 2 diabetes, and she'd never made the connection that the reason her uncle and her father were on dialysis, all these family members that were on dialysis, it had to do with their diabetes. No one had ever made that link that chronic kidney disease and dialysis had to do with diabetes. I mean, she had this big aha moment. And so some of these links were never made for her. And so understanding early on that, okay, now you've been diagnosed with diabetes. Here's what we're going to prevent if we can treat this well earlier on and prevent, deterioration of your disease. And so really not losing the wellness visit. I think that we've lost the wellness visit. We tend to, if we've got patients with multiple complex chronic diseases, we tend to be very reactionary. So we've got to get in that, sacred, let's hold on to that wellness visit. Let's try not to make it a multiple chronic care visit, smattering of addressing all the chronic care issues, but keep it as a truly wellness focused visit of all the screenings we need to get done, making sure we're doing the depression screenings, the cognitive screenings, the age appropriate physical exams that we need to do, looking at the skin, looking at all the things that we need to address that are specific for that individual patient and appropriate for that patient. So tertiary prevention, we have to start with what matters most. We've talked about this a lot, and we'll talk about it a little bit later, more specifically, but that's the thing we start with. Rather than the current guidelines, we start with what matters most. And that's important if you've got a patient that has multiple chronic comorbidities, right? Is what matters most to them, because we may have 5 things we need to address, but our priority is the patient's priority. Then we look at the current guidelines and we address what does the evidence tell us? But then what treatments can we look at that might hit on all 4 cylinders, right? What can we use that will actually target more than one condition? And then, is it financially feasible? Is this the right treatment for our patient? Will it be covered? Can we consider starting this treatment plan? And then after we've done a trial of treatment, did the benefits really outweigh the cost? And did they meet the goal of the patient? Not my goals necessarily, maybe not the target A1C, but did they actually improve the patient's quality of life? Did they improve the goal? And what mattered most to the patient? Did they make an impact on the patient's life? So, and of course, this is an entire lecture on its own. We could go into more detail, but we'll talk a little bit more about these 4 M's. And really, we know these 4 M's, we've touched on this, you've seen this diagram before, but let's go into a little bit more detail. When we look at the mind, we're looking at the 3 Ds. We're looking at dementia, depression, and delirium. And this is really important to tease out, but to approach from that chronic care mentality. When we look at managing chronic conditions, we want to mitigate the risk for developing dementia. So it's really important, of course, to tease out what's going on, but doing those screenings early and regularly. We know that dementia is manageable, but it is progressive. And managing chronic conditions is the key to minimizing risk. So if we manage diabetes well, if we screen and detect sleep apnea, AFib, hypertension, we look at drug and alcohol abuse and treat these conditions early on and screen regularly for cognitive effects, then we can treat early. Mentation, of course, is the just daily cognitive functioning, and this really should be addressed informally at every visit by asking a few questions, but also formally at wellness visits and as needed when there is a particular complaint. And then depression is more common in people with chronic illnesses. So this is something that can often get missed because in older adults, we may miss it due to physical symptoms that persist. So it may not come out as, anhedonia or a lack of, pleasure in doing things that they normally like to do, but maybe there are physical symptoms that are coming out. So we need to really think about depression as one of those differentials. Delirium, of course, is treatable and reversible. It's acute onset, but may be related to medications. So often the most common cause is iatrogenic. So medication review and deprescribing becomes really important when we're looking at delirium. And acute illness or infection or electrolyte and fluid issues, of course, are one of the other most common causes of delirium. So this one is really important. Some of the formal screenings we can do pretty easily to kind of tease some of these things out is really doing that careful medication review, but then looking into doing a mini cog and getting in the habit of doing that pretty regularly anytime there's an issue with memory. But sometimes family reports become very important and building a good rapport with our families and our patients. Mobility, we'll talk a little bit more about mobility. Assessing and observing gait. So watching them walk in the office, watching them walk down the hall. How are they navigating the room? Are they getting on the table okay? Are they using the assist device? And really doing a good fall risk assessment. This should be included and integrated into the HMP of our patients at least once per year. So falls, frequency of falls, difficulties in gait or balance should be assessed, but we should do a more comprehensive assessment if either they've had 2 or more falls, they've had difficulties with gait or balance, or they've sought medical attention or an ER visit due to a fall in the past year. And how we do that, and the reason that's important is because really the leading cause of death for older adults by accident or injury is as a result of unintentional falls. Our multifactorial assessment should include a comprehensive history. So really looking at circumstances of the fall. So was this a trip and slip? Was this a drop attack, a sudden or spontaneous fall without loss of consciousness? Was it syncope? Was there dizziness? Was there an acute medical illness at the time of the fall? Was there a cognitive difference or a change in cognition? Look at the medications. Was there a recent change in a medication, an addition or an increase in dose? And then doing a comprehensive cognitive assessment, looking at their ADLs. How are they doing with ADLs? Doing a comprehensive functional ADL assessment, something such as the CATS assessment, and then doing a thorough physical exam. So not only doing a set of vitals, but a set of orthostatic vitals, doing a general appearance, a good skin exam, a cardiovascular exam, and then a good musculoskeletal that includes gait, and then the time to up and go. And we'll talk a little bit about that in a minute. And then a neurological exam as well. The fall risk factors, this is a great form that I use sometimes just to kind of do a comprehensive fall risk assessment. If I just want to see, how likely they are to do a fall, it kind of encompasses everything. So we're looking at all factors that could contribute to a fall. The other one, the CATS that I was speaking about, this is one that I will do with patients or families, especially if they're considering or struggling with, do I pull a caregiver into the home? Are we ready for a senior living facility? Or, should I be recommending that they go, to something with a higher level of care? So I'll pull this out and I'll actually walk through this with patients and families just to see how independent are they? Do they need a little bit of help? Could they safely stay in the home? Or is it time to maybe get them a higher level of care? And then the time to up and go test, this of course is, downloadable form, and anyone who takes longer than 12 seconds really is at higher risk for a fall. So this is a good assessment to do to assess mobility and fall. There's also a stratified timed based on age, and you can look that up in UpToDate. I've actually found the stratified risk. So, but anything other than longer than 12 seconds really indicates a higher fall risk. And the next one is medications, and really the multiple comorbidities and optimal prescribing is the way we really need to look at this more and more. And I think we've talked about this with diabetes and heart failure both, looking at multiple conditions and can we target? The first thing we have to do is ask ourselves, can this issue be addressed without a prescription? And then identify those interventions that target more than one condition. We always look at the Beers criteria. Another one is the stop-start criteria. But, trying to avoid those medications for older adults that are listed on the Beers criteria. And also looking at, are we prescribing something that may be, maybe treating a symptom of a side effect of something else? Is there something that's going on? What are we treating? So the AGS guidelines for multiple chronic conditions indicate that we need to identify and communicate patients' health priorities and trajectory. Trajectory meaning prognosis, where are they headed? What are our goals? Stop, start, or continue based on health priorities. So the patient's health priorities, and looking at that harm benefit ratio, and then align decision and care among patients, caregivers, and other clinicians as well. So we just really need to advocate for what our patients' priorities are. Medications and deprescribing. So really that deprescribing definition, the planned process of reducing or stopping medications that may no longer be of benefit or may be causing harm. This website in particular is from an institute in Canada, and they've got some great resources for deprescribing algorithms. The goal really being to reduce medication burden of harm while improving quality of life. And I really, really liked some of the materials that they have. We need to look at it during every wellness visit. So when we're reviewing their regimen, really looking at their chronic conditions and making sure that everything that they're on is absolutely necessary. Are there changes that need to be made? Have their conditions still exist? Do they still exist? Are they still relevant? Looking at all the chronic care visits? Are we still in line with the latest evidence, the guidelines? Are the medications doing benefit, or are they doing more harm than benefit? So really looking, at their during their chronic care visits. Episodic visits. So again, when they have a new symptom, is this a symptom that's being caused by something we've got them on? Are they having a new symptom because of a recent dose change or dose increase? And are we trying to prescribe something for a symptom that may be caused by a medication they're on? So not prescribing something to treat a symptom of a side effect. And then after an incident, injury, or accident, especially falls, what do we need to look at on their medication list? Do we need to take a look at, at precipitating factors that could have led to the fall itself? This is an example of the deprescribing algorithm. Proton pump inhibitor, I love to use this example because how many of our seniors are on PPIs, and they've been on them for years. And these algorithms are great because they tend to help us kind of guide the conversation. Many older adults may not want to come off of some of the medications that they've been on for many years. So it kind of helps have that conversation. This one, is the indication known? And if so, can we at least go to a lower or standard dose? Are they on a high dose? Decrease to a lower dose, do a trial. If they are, if the symptoms are well managed, go ahead and stop it or stop the PPI altogether, and then monitor. Really, PPIs are not meant to be, be extended past an 8 to 12 week regimen anyway. So really looking at what they're on it for, and then, trying to decrease and or stop. And then these are some of the other the other side of the algorithm, some of the other tips and tapering recommendations. So I thought this was one of the good ones. There are multiple deprescribing algorithms that are there as a resource. Transitions of care. Just wanted to talk about this because this is a really important aspect of medication management. And I thought these were really interesting stories. This is from a JACO article from 2012. It's old, but still relevant. So I'll just read these. An 80-year-old retired school teacher visited the emergency department 4 times in a month for exacerbations to a mild heart failure condition, twice requiring hospitalization. When provided with discharge instructions, she can repeat them back accurately. However, she doesn't follow through with the instructions after returning home because she has not yet been diagnosed with dementia. A 68-year-old man is readmitted for heart failure only 1 week after being discharged following treatment for the same condition. He brought his pill bottles in his bag. All the bottles were full, not one was open. When questioned why he had not taken his medication, he began to cry, explaining he had never learned to read and couldn't read the instructions on the bottles. After falling at home, a 78-year-old woman received 3 new prescriptions from her primary care physician during the exam. Her blood pressure was 160/90. The doctor instructed her to start taking the new medication for hypertension the same day and to stop taking her current blood pressure medication the following day. 2 days later, the home care nurses came to see her. The patient complained of a headache and dizziness, and the nurse noted that she had a blood pressure of 190/96. When the nurse asked what medication she was taking, the patient said she had stopped taking her old blood pressure medication like the doctor told me to. When the nurse asked about her new medication for hypertension, the patient became upset and said that she didn't have them yet. When the nurse asked her why, the woman said, because we don't have the money to get them, that's why. The woman was on Medicare, but they didn't have enough money for the copay amounts for the new medications. All very familiar scenarios. I'm sure we've all had similar conversations with patients. So my question, why does this matter for chronic care? Well, it leads to increased readmission rates. We know this about transitions of care. When we fail to communicate, or when those plans are missed, and the patients don't get the communication they need, they have increased in mortality and morbidity. There are adverse events that tend to happen. And of course, this is just that lapse in communication. There's delay in treatment and support. There's additional primary and care and ED visits after discharge. Additional or duplicated tests are lost to follow up. And there's emotional, physical, and mental pain and suffering. And there's patient and provider dissatisfaction with care coordination. So we're in a unique position to be a part of the solution. And a lot of this, has to do with policy. I think with the acceptance of, EMRs and the fact that multiple institutions are using similar EMRs with, Care Everywhere, and we can share. Record sharing has really opened up the avenues for being able to have access to medical records, but these are opportunities where we can assist older adults. We can't assume that they, understand or knew exactly what would happen. And when we're caring for older adults, we have got to ask those bottles to be brought in. We have to look through the bottles. I had a patient where, just had a horrible time, kept getting syncopal, would come in, blood pressure tanking, we kept discharging medications and things were happening. Finally brought the bottles in and realized he was on furosemide and Lasix. And so, there are these problems where we assume they know both meds. He was getting one from Express Scripts and one was from a local pharmacy. So there weren't communication between the two pharmacies, and this just wasn't, he was filling them at different pharmacies, and and these are the things that happens, and it's not intentional, and it's not intentional on the patient or the provider's part, but we have to dive deeper and investigate. So just a group discussion. Have any of you had a catastrophic or near miss transitions of care experience? And I just want to open it up. You're welcome to just speak out. And share. Would love to hear. Doesn't have to be something.
The chat is also open.
Yeah.
You can type it in the chat too if you.
Yeah,
can.
exactly. And it doesn't even have to be an experience you had as a provider or a clinician. It could be something that happened with a family member, or something a family member said or happened with their meds.
So if I have one, if no one else has an example. I was seeing a patient in one of our assessment clinics, and he and his daughter, they're always asked to bring all their medications with them. And so they brought 3 or 4 bags full of stuff, and they had a really nice spreadsheet delineating all of it. And I thought, oh my gosh, this is so great. You're so on top of it. But how did you end up on such a long list? And so he told me this story, which is really a systems failure. He went to get admitted to the hospital. He was asked to bring all of his meds with him. They took them away from him. He was in the hospital, got discharged with a new set of medications. Everything was explained to him. And then the discharge person brought in the old bag of meds. So now he's got 2 sets of medications. Some of them are the same. Some of them are just, some of them are written for generics. Some of them are written for brands. He's not a medical professional. He has no idea that there are all these duplications. He went home and he was back in a complete mess. So these examples that Dr. Campbell pointed out are really excellent, but sometimes it's just the way we do things in a hospital or in a practice. It's not completely thought through and doesn't make sense. So sometimes these mistakes happen because of that.
Absolutely. That's a great example. Great example. And I think the other thing, and you're totally hitting on this, Dr. Gurvich, is I've also had patients where they load the pills and they had one manufacturer and then it switched manufacturers. So to them, the pill was different.
Yep.
And so it was pink. It used to be pink and oval, and now it's round and blue. And so when they were loading at some point, so they've doubled up because they're thinking they're taking 2 different meds. And
right.
And again, or Express Scripts, they're getting their 90-day, and then they changed a dose and they refilled their temporary new dose at CVS. And so, again, it's system problems, right? It's not intentional. It's nothing that, that we intentionally do. I'm going to read what Jennifer Martin said. I had a patient who was doubling all her medications, all of them, because she was dismissed from the hospital. They did not go over the previous meds. She came to my clinic with her daughter completely incoherent due to overdosing on everything. I cannot remember all her meds. This was years ago to previous clinic. Yep, absolutely. Absolutely. So So yeah, this is a really common problem. And I think the bringing everything in, it's just astonishing what we discover when we actually get the meds and take a look at them and explain everything, and really also telling them what they're for, what they're indicated for, what they, understanding, because we really, even patients who have been on their meds for years, really just don't understand some of the reasons they were taking them for. So it really helps empower the patient, really empower the patient. So the next thing I wanted to talk about too was really what matters most, right? We talk about this a lot. This is probably the most important thing that we need to talk about. And not only what must we be willing to listen, but we also not just ask, but listen. And creating space to listen is so difficult when we're slammed and we have these complex patients and they come in and they've got so many chronic problems, but we really have to create space to listen and be mindful. And stop thinking through our next patient or planning, or but also then advocate, not just for the patient, but with their family members, and express and advocate for our patients with their family members and with other team members and specialists, but also to help patients explore this. Sometimes it's helpful to give examples. What I sometimes will do, because this may be the first time a patient's ever been asked what matters most to you. So I will say, for example, does it matter more for you to have this certain side effect, or is it more bothersome for you to inject yourself with insulin? Is it going to be worse for you to have this, deal with the diarrhea from, these high doses of metformin, or are you willing to give yourself an injection? Are you more petrified of needles? Are you willing to deal with the neuropathy and the pain in your feet? Or would you rather do the needles, a couple times a day so we can get your sugars under control? So I kind of do an either or sometimes. Another thing you can do is open-ended questions to kind of, what does your perfect day look like? What does a perfect day for you look like? So I will sometimes ask that question and let them just describe their perfect day. And you can really get to know your patients, what matters most, because it'll come out in their answer. And so you get to hear about what matters. And then sometimes providing tools. So the link that I provided you here, this picture is actually the images from this guide for patients and caregivers. And it's a very simplified booklet that helps patients answer the question, what matters most? And it's a conversation guide for patients, really, to what are your goals for your life, your short-term goals, your long-term goals, what matters most for you. And it's all guided around, kind of life and healthcare goals. And so really, it's a good tool. So sometimes you really have to help them get to the bottom of this by guiding them in these ways. The other thing to do is create space. I'd like to ask you a poll question. I'm curious as to how many of you practice something called mindfulness. If you have a habit for yourself of practicing mindfulness throughout your day to create space for you so that you can be able to listen. So we'll go ahead and launch the poll if you can, Nika. So do you engage in a mindful practice during your daily clinical routine? So do you do anything to help you as a provider, clinician, nurse, resident, stay mindful? And Nika, when you're ready, when you see that most everybody's filled it out, go ahead. Okay, so majority of people said rarely. Some people said never. Okay, 30% of people said often, which I love. But most of us, majority said never or rarely. Okay, so, and that's common. That's pretty common. So I just wanted to guide you through a couple of just some suggestions of ways you can do this, because if we are not creating space to be mindful, and making it a habit. It's difficult for us to stay in the moment and hear what our patients are saying, or listen, actively. So abdominal breathing, this exercise is a 5-7-8 rule. And what you do is you inhale for a count of 5, hold it for a count of 7, and then exhale for a count of 8. Once you do this 5 cycles, by doing this abdominal breathing, so inhale abdominally, not with your chest, not superficially up here, right? You have to do abdominal inhalation because that's really where the good breathing happens. And you do this 5 cycles and that parasympathetic nervous system will take over. And that gets you out of the fight or flight and helps you really lower your heart rate, really slow the breathing down and start to really relax physiologically. Really kind of helps you center. And so another one you can try is 30-second mindful meditation. And this is 3 cleansing breaths. So 3 of those good abdominal breaths. And then notice all 5 senses. So ask yourself, what can I hear? What can I see? What can I smell? What can I taste? And what do I feel? What do I feel in my body? And so you can close your eyes and do that. And then you can just kind of, be aware of your surroundings and be aware of what you're sensing, seeing, feeling, hearing, touching, and tasting. And then a loving kindness meditation. I like this one, especially if you're feeling very angry or tense or frustrated, to do a loving kindness meditation. May I be happy, may I be well, and may I be free from harm. And you can do this also to someone else. So you can give a loving kindness intent toward a patient or toward a member of your family or a colleague. And so you may say their name in your mind. So a loving kindness, may you be happy, may so-and-so be happy, may they be well, may they be free from harm. And then gratitude, 3 cleansing breaths. So the 3 cleansing abdominal breaths, and then I'm grateful for, and just think upon something you're grateful for. So these are just some tips of things to do. It takes time to develop a habit. I suggest to people that they set an alarm. And even if you don't do it often, just set an alarm 3 times a day, 3 times a day throughout your clinical shift, and start to just do this. And it can be really quick. You can do the loving kindness meditation in less than 3 seconds. So I'd encourage you to try that. And self-care, we'll talk about self-care. It's really important. It's so important that the IHI changed our triple aim to a quadruple aim because they realized that the improved provider well-being needed to be the 4th aim. So care of the caregiver is important. The National Academy of Medicine, formerly the IOM, developed a collaborative action in 2017 to really look at provider resilience and well-being. And in 2019, they wrote an article and really looked at resiliency of providers, recognizing that, healthcare professionals in pharmacy, nursing, and medicine really we need to fortify our efforts to look at resiliency and prevent burnout, clinician burnout, because it's that important. One of the things they actually looked at was that it has to start during school, during the education. So of nurses, physicians, and pharmacists, it actually has to begin in school. And so they're really calling for curriculum that's based in resilience training. That's how important it is. And self-care is the practice of taking an active role in protecting one's own well-being and joy, deliberately spending time engaging in activities that nourish you, the avoidance of self-destructive behaviors that exhaust and frustrate you or do harm. And self-care is not selfish. So we do have to protect that. One of the things that I also encourage people to do, in my previous practice, we found that we were all getting burnt out. We found that there were some of us that would not set boundaries with patients and would answer non-urgent messages and emails from patients over the weekend and in odd hours at night. And it set a precedent that patients would expect that. And so we found it helpful. We finally said, we can't do this. We have to set boundaries. We have to take care of ourselves. It's ruining our family life isn't becoming a priority. Our partners are getting frustrated, our children. So we, as a practice, we had to set some boundaries up, and we decided to do it as a team. And it really changed. It completely changed our practice. But it's helpful if you can do it as a team. Say, okay, if one person's answering emails and messages, non-urgent messages at midnight, we can't, and on every weekend, the whole, but after setting boundaries, the patients really backed off, and it really helped set a new precedent for our practice. So just something to consider. I know that's not always realistic depending on the kind of practice you work in, but patients respect it. And if you do it as a team, it's a lot easier to do. And I'm telling you, it will save you, and you will be a better practitioner because of it. But something to think about. Creating space. One of the things that I like to do for patients is, rather than be reactive, be proactive. So setting some time for, rather than these rescue visits that are when patients are in exacerbation, doing chronic care talk visits. So these are scheduled as follow-up visits, but really the aim is for goal setting, planning, education, and self-care management, not really even physical assessment visits. These are just talk visits. Let's talk about your CHF. Let's talk about your diabetes. Where are we at with this? They're very patient driven. It's an opportunity for them to bring up concerns, questions, clarification. And these are great to do as telehealth visits, where the focus again isn't the physical. They're not in an acute exacerbation. It's a time really to say, where are we at? How are your meds? How are your side effects? These are really great visits to make sure you're doing, so that we're not just reacting to, the ebbs and flows of exacerbations, but really doing this as setting aside time and really allowing the patient to drive the visit for what matters most to them. And are we meeting your goals? What would it look like if our visits were, we asked the patient, are we addressing your goals? Are we meeting your goals? How are you feeling? Are we getting the quality of life you envisioned? Are you feeling well? Are you doing well? So again, proactive rather than reactive. Creating space, doing trials of care. So one of the things I've found that's really helpful for buy-in is to really set up, we're going to do this as a trial. This is the premise, and it's similar to the premise of addiction. When we talk about addiction, we talk about one day at a time, right? When we're trying to get patients to quit smoking, or if they're alcohol abusers or drug abusers, we talk about giving things up one day at a time, just get through one day at a time. And so when we think about looking at making change and principles of motivational interviewing, thinking about trials of care. So when patients are hesitant, don't think about doing this forever. Don't think about doing this for a year. How about we try this for 2 weeks? How about we try this for a month? How about we just do a trial and then we see how it goes? And sometimes that really helps patients to buy in and say, okay, I'll give you a month. I'll give you I'll try this for a month. Let's do it. Or I'll try this for 8 weeks. Okay. So just kind of framing it that way. And sometimes they'll realize that's a lot less scary than thinking about forever, thinking about this is a life sentence or this is the rest of my life. And so thinking about framing it that way for patients. Motivational interviewing or Mission Impossible. Really engaging the patient in shared decision-making does involve motivational interviewing. This is one of the best tools we can use. It's made up of 4 main principles. Engaging, focusing, evoking, and planning. And many of you, I'm sure, are familiar with this, but really these were, kind of, again, looking at, psychological components of, the stages of change and really, getting patients to buy in. But really it's, that process of, are you ready and are you willing to make this change? And this is where the patient's in the driver's seat. And so I wanted to talk a little bit about one of the tools that's, and it goes along with the boat and river. It just happens to follow along with my analogy, but it's the oars, right? And so asking those open-ended questions. So, saying things like, what barriers do you think are going to prevent you from, complying, doing a diet? And don't use the word comply, but, I like to ask what barriers are you encountering, or what do you think is going to be the hardest thing for you? And asking those open-ended questions rather than yes or no, and affirming them, so when they make a little bit of change, or where you hear change talk, I really appreciate that you've attempted to do that. I really think you've done a good job at making that little change. Patients tend to downplay when they've done something small, and we need to affirm when they've done something small. We need to affirm them when they've made even the smallest of change, because that's a big deal. I thank you for taking the time. Thank you for showing up to your appointment today. I think it's a really big deal that you're even here. And reflective listening. So restate what they've said, the patient has said, and make sure we correct and summarize the visit so that we're all on the same page, so that we haven't missed the mark. Because sometimes we can come out of that visit and we think we know what just happened, but we don't have any idea. You ever done that with a patient where you're like, wait a second, what just happened? So really making sure we understand where the patient's at, summarize the main points of the whole visit, the conversation, so that we're all clear on the plan, but really making sense of, is there a misconception? Is the resistance to change or the reason for not wanting to change because of a myth or something that they are not understanding? You know, oh, if I start on insulin, I'll never, you know, if I start giving myself shots, that means I'm going to get an amputation. I've literally heard that. Shots lead to an amputation of my foot, you know, with diabetes. So really kind of clarifying some of the myths. And that's that ask, provide, ask. So ask permission to provide new information, provide some information, and then ask if that helps to make sense. Does that make sense? Do you understand what I'm saying? And really, you know, the using the sliding scale approach, I'm just going to clarify one more point because we're running out of time. But, you know, when a patient says, I'm going to cut back, I'm going to stop drinking all my soda. Why? Go to, instead of drinking 4, drink 2. How about that? And they go, wait a second, that's an option. I can go from drinking 4 to drinking 2. Well, yeah, let's make this realistic. I mean, don't kill yourself. So I think really using that sliding scale approach and helping patients come up with something that's reasonable is always, you know, helpful for patients, because they go, oh, that I don't have to be all or none. And so really making things reasonable and helping patients to understand that let's make it realistic. Let's make it something that is not extreme, something that's doable for you. And when they see you're willing to work with them, that's a really, you know, really beneficial to building that rapport and trust. I wanted to ask you guys, do any of you have questions or techniques that you use for motivational interviewing, or to get a feel for when your patients are ready to change? Or you guys can write it in the chat. Almost out of time. A couple of last thoughts, things I wanted to share. And I'm guilty of doing some of these things, but some do's and don'ts. You know, do roll with resistance. You know, when patients don't want to do something, don't push it. You know, roll with it. Pause before discussing change. Listen to the patient's insight. They may have a really good reason. They may have trauma surrounding something that happened, and there's just no way they're going to do that because they have an experience and a trauma experience from when someone was hospitalized, and there's a really good reason they have resistance to that change. You know, collaborate with the patient, work with them. You know, again, they're in the driver's seat, they're rowing the boat. They get to decide which fork in the river that they're going to take. Don't pressure, fix, or control. Don't shame or blame. Shaming is one of the worst tactics. Same with scare tactics. Scare tactics, you know, educate, but don't, you know, scare tactics. And then don't neglect to praise a patient's efforts, no matter how small it is. Praise what they've done, because what that little step forward could have been a mountain that they had to climb. So don't forget to praise their efforts. I think that's all I have. Here's some additional resources. A conclusion. So remember the boat, empower your patients to row their own. It's never too late to promote health and wellness, even in the midst of chronic disease. The 4 M's must be considered in all aspects of care. Ask, listen, then don't forget to advocate for them. And then create space for you, engage in self-care, and then engage in MI to accomplish the mission impossible. So thank you for listening today. Here's some additional resources that I wanted to also include. And most of the forms and things that I presented also have some links, so you should be able to access them.
Thank you so much, Dr. Campbell. That was a very thoughtful, wonderful, comprehensive session to actually close out our series. So thank you so much. Does anybody have any questions for Dr. Campbell before we close out this series? Or any of our hub team members that are here today? Okay, let me share our end screen. So as you all know, we have our CE form that you'd want to fill out if you would like CE credit. We also do have an evaluation form, and this is very helpful as we plan our next series. Please be on the lookout for future emails. So if you want to register for our future series, that will be coming out to you via email. So be on the lookout for that. And I will be sending a follow-up email with these slides. Dr. Campbell included a lot of really helpful resources and links, and those will be included in the slides that we share with you, as well as the recording that will be sent to you at next week as well. I want to thank our hub team for help organizing this series and presenting. Thank you all so much. And for all of you who have been at all of these sessions, thank you for joining us. And again, we hope to see you at our future series. Thank you so much. And thank you again, Dr. Campbell, for today's session. I hope you have a wonderful weekend.
Are we done?
Yes.
Okay. Okay, thank you.
Thank you, guys.